This is Rebecca Brady. I'm the Medical Director of the Ohio American Academy of Pediatrics Maximizing Office-Based Immunization Program, and also of the Meningococcal B QI2U program. This presentation will discuss disease due to the bacteria Neisseria meningitidis, also known as the meningococcus, and the vaccines that are available to prevent meningococcal disease. Next slide. My three objectives are: number one, to discuss Neisseria meningitidis, the meningococcus, and its associated diseases. Number two, to review meningococcal ACWY vaccines. And number three, to review meningococcal B vaccines. Next slide. Neisseria meningitidis, also known as the meningococcus, is a bacteria that stains pink, so it's gram-negative and appears as two circles or diplococci when viewed under the microscope. The upper right photo shows a gram stain of Neisseria meningitidis. The lower right photo shows the different parts of the bacteria. The outermost layer, which is depicted in brown, is the polysaccharide capsule, which is made up of polysaccharide sugars. Just below the capsule is the cell wall, which is depicted in blue. Between the polysaccharide capsule and the cell wall is an outer membrane that contains proteins, and these outer membrane proteins project outward. In the very inner part of the bacteria, which is depicted in the yellow, you see DNA, the cytoplasm, and the ribosomes. The polysaccharide capsule and the proteins that project out from the cell wall are important antigens. Antigens are parts of the bacteria that the human host recognizes and then mounts an immune response to in an attempt to protect the human host from disease. Next slide. The meningococcus tends to cause disease with an abrupt onset that is severe and progresses rapidly. The different categories of disease include meningococcemia, which means the meningococcus is present in the blood. This can lead to sepsis with multi-organ failure. This bacteria can also cause meningitis, which is an infection of the meninges, the covering over the brain. The meningococcus can also infect the lungs, leading to pneumonia, and it can infect the joints, leading to arthritis. The case fatality rate for meningococcal disease is 10 to 15%, and this rate is somewhat higher in adolescents. Next slide. This photo is of a 2-year-old boy with meningococcemia. So he has meningococcus circulating in the blood. This is caused sepsis and purpura fulminans. Purpura fulminans means he has bruising and problems with blood clotting in the small blood vessels throughout the body. And so what you see scattered over his body are these large areas of bleeding that look like large bruises. Next slide. This slide lists some of the risk factors for acquiring meningococcal disease. These risk factors include people who have problems with the function of their spleen or the complement proteins. The spleen aids in clearing the meningococcus from the blood. Complement proteins are proteins in the blood that aid in recognizing the meningococcus as a foreign invader, so the immune cells can attack and kill it. If an individual has HIV infection, along with one of these above indications, either problems with spleen function or problems with function of the complement proteins, then they're also at risk for meningococcal disease. Family members of an infected person are at risk for acquiring meningococcus because the bacteria is transmitted by the nose and throat secretions of people who have the bacteria in these locations. Smoking is also a risk factor, including passive exposure to smoke. Recent upper respiratory infections, because the cold virus causes inflammation in the nose and throat, and if the meningococcus happens to be there, that helps it penetrate the nasopharyngeal mucosal cells and enter the blood. Crowding is another risk factor. If there's close contact between individuals, this allows the more easy spread of nose and throat secretions. And college students living in residence halls, again, are at increased risk because of close physical contact. People without any of these risk factors can also develop meningococcal disease. Next slide. So given the severe manifestations of meningococcal disease, prevention is an important public health goal. And by preventing disease, we're also preventing death and long-term complications in survivors. Looking at another example with another cause of bacterial meningitis, Haemophilus influenza type B, or Hib, a vaccine was the most important strategy in preventing disease. Since the Hib vaccination was added to the infant schedule, Hib disease has decreased over 99%, from over 20,000 cases to now less than 20 cases per year. So the hope is that meningococcal vaccines will have a similar impact. Next slide. This slide is from the CDC National Notifiable Diseases Surveillance System. It looks at the incidence of meningococcal disease by age in the United States over the period 2015 to 2013. On the y-axis is the incidence per 100,000. The x-axis divides them into different age cohorts. The largest peak in incidence is in children 0 to 4 years of age. There's a second peak in individuals 15 to 25 years of age. And then the incidence also starts increasing again in the elderly, especially those 85 years of age and older. Next slide. There are different types of Neisseria meningitidis. They can be classified into different serogroups based on the composition of their polysaccharide capsule. 13 different serogroups have been described. Some meningococci do not have a capsule, and they're referred to as non-typable. Almost all severe meningococcal disease is caused by serogroups A, B, C, Y, and W. And protection against meningococcal disease is serogroup specific. Next slide. So protection acquired through infection and disease is serogroup specific. Individuals who survive meningococcal disease due to serogroup B make an immune response that's specific to serogroup B. They're still susceptible to disease from the other serogroups. Next slide. This slide is examining Neisseria meningitidis, serogroup B. It's associated with epidemics in sub-Saharan Africa. So the yellow shows the countries in the meningitis belt, and the more gold color is those that had the highest epidemic risk. Neisseria meningitidis serogroup A disease is rare in the United States, but there are many people who travel to these areas for work and tourism, so offering them protection against the acquisition of meningococcal serogroup A disease is important because many of these countries do not have advanced ICU care to manage severe meningococcal disease. Next slide. This slide is also from the Centers of Disease Control and Prevention. It examines the incidence of meningococcal disease among adolescents and young adults by serogroup over the period 2014 to 2016. The y-axis is the cases per 100,000. The x-axis is the different ages. The blue is for B, the red is for C, the gray is W, and the yellow is Y. So what you can see here, between 2014 and 2016, there were 1,178 cases of meningococcal disease that were reported. 166, or 14.1% of these cases, occurred in persons ages 18 to 24 years, and serogroup B was the predominant serogroup in this age group, as evidenced by that high blue peak. Next slide. So if we wanted to design an ideal meningococcal disease, we would have all the types in it that usually cause invasive disease. So it would cover for A, B, C, W, and Y. And it would offer protection to the age groups who have the highest incidence of disease. So those would be young infants, adolescents and young adults, and the elderly. And it would likely need to include antigens based on the major antigenic determinants, which include the polysaccharide capsule and or the outer membrane proteins. Next slide. An important point to remember is that young children do not make good immune responses to polysaccharide antigens. So a protein conjugate may need to be added to the capsular polysaccharide to improve the immune response. And that's similar to what's done with the pneumococcal polysaccharide protein conjugate vaccine. This is how the pneumococcal polysaccharide protein conjugate vaccine, which is part of the recommended immunization schedule to protect infants against pneumococcal disease, is made. Next slide. So with going about trying to make this ideal meningococcal vaccine, it would be a meningococcal A, B, C, W, Y polysaccharide protein conjugate vaccine. And so with trying to make it, they added the different antigen components and then tested. The meningococcal ACWY polysaccharide protein conjugate vaccines were safe and produced good immune responses when tested in clinical trials. However, when the B part was added, the immune response was poor. So scientists set about further studying the meningococcal B polysaccharide and realized that it resembled a self-antigen, and that's what's depicted here in these little red ovals. This is the capsular polysaccharide of meningococcal serogroup B, which looks like a self-antigen. A self-antigen means that it looks like a normal part of the body, and therefore the body does not recognize it as foreign and make good immune responses to it. So the meningococcal ACWY polysaccharide protein conjugates progressed through the clinical trial process and were licensed in the United States, while scientists were still working on a vaccine against Meningococcus serogroup B. Next slide. So we're going to look first at these meningococcal ACWY vaccines. There are two of them that differ in terms of the type of protein conjugate they have. So there's the Meninge ACWY CRM vaccine. The CRM is the protein conjugate. There's also the Men ACWY D vaccine, where the D is the protein conjugate. Both are administered intramuscularly. Either can be administered as part of the recommended schedule for adolescents. and the adolescent recommendation is 2 doses of the same formulation, with the first dose administered at 11 to 12 years of age and the second dose at 16 years of age. Next slide. A few caveats about the meningococcal ACWY vaccines. Adolescents who receive their first dose at age 13 through 15 years should receive a booster dose at age 16 through 18 years. Adolescents who receive a first dose of meningococcal ACWY vaccine after their 16th birthday do not need a booster dose unless they become at increased risk for meningococcal disease. And this meningococcal ACWY vaccine is the one referenced in the Ohio meningococcal laws, or meningitis laws, as some people often refer to them. Next slide. So the Ohio meningococcal law is a mandate that started with the 2016 to 2017 school year. It requires students to be immunized against meningococcal ACWY disease with 1 dose of Men-ACWY vaccine required before 7th grade. The second dose of Men-ACWY vaccine is required before 12th grade. If the first dose was given after the 16th birthday, then the second dose is not required. The legislation does allow for medical and personal exemptions. Next slide. Regarding colleges and meningococcal ACWY vaccines, there was legislation passed in Ohio in 2005 that requires college students to disclose their Men-ACWY vaccination status to the college. The law, however, does not require vaccination. It also does not require the institution to provide or pay for the vaccine. Some colleges and universities have policies requiring vaccination against meningococcal disease as a condition of enrollment for either the incoming first-year students living in residence halls or for all incoming students. Also, for ease of program implementation, persons 21 years of age or less should have documentation of receipt of meningococcal ACWY vaccine not more than 5 years before enrollment. Next slide. So next, going back to meningococcal B vaccines, as we already discussed, scientists were continuing to work on developing them, realizing that the polysaccharide capsule was similar to a self-antigen, so it was port-inducing immune response. So they focused on the outer membrane proteins as antigens for developing the meningococcal Serogroup B vaccines. And in the diagram, these outer membrane proteins are FHbp, which is factor H binding protein. There's NADA, which is Neisseria adhesin, NHBA, Neisseria heparin binding antigen, and POR-A, which is an abbreviation for porin A. Next slide. So 2 meningococcal Serogroup B vaccines have been approved by the FDA to protect against Neisseria meningitidis Serogroup B disease. The CDC has not indicated a preference between these 2 meningococcal B vaccines. Either can be used. Both are only licensed for use in persons 10 to 25 years of age. One vaccine is Men-B-FHbp, which has 4 components from the outer membrane derived from different strains. The other vaccine is Men-B-FHbp, which contains the FHbp proteins from both of the FHbp subfamily types. So the important point here to remember is that Neisseria meningitidis Serogroup B isolates are not all identical. They all have a Serogroup B polysaccharide capsule, But the other components, including the outer membrane proteins, may be different between different isolates. There are different strains and subfamilies of the outer membrane proteins, so vaccines derived from these components differ in their ability to protect against meningococcal serogroup B disease. Next slide. A routine adolescent meningococcal B vaccine recommendation would be expected to prevent 15 to 29 cases and about 2 to 5 deaths per year, assuming all eligible persons were immunized. So currently, it's not cost-effective to immunize all adolescents against meningococcal serogroup B disease. Therefore, the Advisory Committee on Immunization Practices, the ACIP, of the CDC, has developed 2 categories of recommendations for meningococcal B vaccines. Next slide. So first we're going to look at the Category A recommendation, which this basically means recommended. Give the vaccine unless there's a contraindication or precaution. The other adolescent vaccines, including Tdap, HPV, Men-ACWY, and influenza, all have a Category A recommendation. The only individuals that have a Category A recommendation for meningococcal B vaccine are those individuals 10 to 25 years of age who have one of the following problems: a complement protein deficiency, problems with function of the spleen, those who are at risk during an outbreak of meningococcal B disease. The CDC will aid in defining outbreaks and those at risk, and microbiologists who routinely work with Neisseria meningitidis. Next slide. So for everyone else, the Category B recommendation is used. This is permissive, meaning adolescents, their parents, and young adults, along with their caregivers, can decide on an individual basis. Either meningococcal B vaccine can be used. No preference is made. Based on the currently available information, the Men-B vaccines are safe and effective. The preferred age of receipt for Men-B vaccine is 16 to 18 years, but they're licensed up to age 25 years. And the reason for this permissive recommendation is because meningococcal serogroup B disease is rare, the vaccines are expensive, and currently it's not cost-effective to recommend them for all adolescents. The degree of protection likely varies depending on the degree of antigenic similarity between the wild-type Meningococcus and the strains used in preparing the vaccine. The duration of protection is also still being studied. Next slide. Both types of Men-B vaccine are covered by vaccines for children, so up to 18 years of age. Private insurance carriers vary in their coverage of Men-B vaccines, so the family should check about coverage before administration. Here in Ohio, since they've been licensed now for several years, we're seeing that most of the private insurance carriers are covering them. And then colleges can decide on an individual basis as to whether they recommend meningococcal B vaccines for first-year students who will be living in residence halls or other entering students. So again, it's really best to check with the college as to what they recommend. For example, if the college has had a prior outbreak of meningococcal B disease, they may be more likely to recommend Men-B vaccines for entering students. Next slide. So as mentioned on the previous slide, any potential college students should check with the student health department at their college regarding vaccine recommendations. The manufacturers of meningococcal B vaccines are advertising directly to the lay public, so healthcare providers need to be prepared to address their questions. Next slide. These are some other meningococcal B vaccine considerations. The two Men-B vaccines, Men-B-4C and Men-B-FHbp, are not interchangeable, so the same type of vaccine should be used for all doses. Minimum intervals have not been defined, so the schedule should be used. Meningococcal B vaccines can be administered at the same time as other vaccines in a separate syringe and at a separate site. Next slide. Regarding the Men-B-4C vaccine, the schedule is 2 doses, with the first dose given at day 0, the second dose at least 1 month later. The contraindication is a severe allergic reaction to a previous dose of meningococcal B vaccine or any of its components. Regarding adverse events that have been reported in clinical trials, about 20 to 29% developed severe pain at the injection site. 12 to 13% reported severe muscle pain at the injection site. The use of antipyretic medication was not measured. Regarding the Men-B-FHbp vaccine, it may be given as either a 2 or 3 dose schedule. The 2-dose schedule is 0 and greater than or equal to 6 months later. The 3-dose schedule is the first dose at day 0, second dose 1 to 2 months later, and the third dose 6 months or more later. The 2-dose schedule should not be used for individuals at high risk of meningococcal Serogroup B disease, for example, those in the Category A recommendation groups. Again, the contraindication is a severe allergic reaction to a previous dose of meningococcal B vaccine or any of its components. Regarding the adverse events that have been reported in the previous clinical trials, 5 to 8% developed severe pain at the injection site, 1 to 3% developed severe muscle pain, and 17 to 28% used antipyretic medication. Next slide. This slide examines the adoption of meningococcal B vaccine recommendations. The references at the bottom, it was a study published in Pediatrics in 2018 with Allison Kemp as the lead author. This was a survey via email and internet of a nationally representative sample of pediatricians and family practice physicians that was conducted from October 2016 to December 2016. They assessed factors associated with discussion of the Meningococcal B vaccine, the factors that influenced the decision to recommend the Meningococcal B vaccine, and actual delivery of the Meningococcal B vaccine. Next slide, looking at the results, the response rate was 72%, so return of 660 out of 916 surveys. Regarding discussion of the Meningococcal B vaccine during routine visits, 51% of pediatricians, only 31% of family practice physicians reported that they discussed Meningococcal B vaccine during the routine visits. Among those who discussed this vaccine or often or always, 91% recommended the Men-B vaccine. Among those who never or rarely discussed the vaccine, only 11% recommended the vaccine. And then when asked if they currently administer the Meningococcal B vaccine, 73% of pediatricians said yes. Only 41% of family practice physicians indicated that they currently administer the Meningococcal B vaccine. Next slide. Looking at the factors that increase the likelihood of recommendation, for 89%, it was having knowledge of meningococcal B disease outbreaks. 62% reported knowing the disease incidence. 52% said knowing the vaccine was effective, and 48% said it was important to know the vaccine was safe. Looking at factors that decrease the likelihood of recommendation, the fact that it was a Category B recommendation, 45% indicated that that was a reason that made them less likely to recommend this vaccine. And the other big factor was a lack of knowledge about meningococcal B vaccines. So in conclusion, meningococcal disease has a high case fatality rate in adolescents and young adults. Meningococcal ACWY vaccines are recommended for all adolescents. Meningococcal B vaccines are permissive for healthy persons 10 to 25 years of age. They're required for those who are at high risk of invasive meningococcal B disease. Physicians have gaps in knowledge about meningococcal B disease and vaccines, and this is the major driver in their decision to discuss these vaccines. So the hope is that by viewing this program, we've now improved your knowledge about meningococcal disease and also the meningococcal vaccines.